Hi guys, so this week I will be covering chapter 23, which is the clinical and healthcare epidemiology and evidence-based healthcare chapter. So clinical and healthcare epidemiology. Clinical epidemiology is considered a basic science of medical practice that informs diagnostic, prognostic, and therapeutic clinical decisions related to individual healthcare. Healthcare epidemiology broadens the scope of clinical epidemiology to include various types of healthcare settings, not limited to the acute care setting. Formerly known as hospital epidemiologists, aka infection preventionists, historically the hospital epidemiologist was primarily focused on infectious disease, epidemiology within the hospital setting, and nosocomial infections. The hospital epidemiologist was also responsible for the development of patient safety programs and developed occupational health programs in collaboration with employee health for the hospital employees. And then nosocomial infections, or HIA, hospital-acquired infections, is defined as an infection that is acquired during hospitalization and which was not present or incubating at the time of admission to the hospital, or an infection acquired in the hospital that becomes evident after discharge from the hospital, or a newborn infection which is the result of exposure during delivery. The standard time period for HAI is 48 hours or 2 days after hospital admission. Nosocomial infections and HIA rates. High rates. We're just going to call it high. So there are several types of high rates that can be calculated. A hospital-wide high provides an overall infection rate for the entire hospital. It can be calculated for a month, quarter, or year. And this slide shows the formulas we can use to calculate these rates. So specifically for that hospital-wide one is this first little point here. And then we can also use these formulas to create comparisons at the unit level of the hospital, as shown in the second bullet point here. And then we can even differentiate the rate for infection on a given unit or the rate of patients infected for a specific unit, as shown in the third formula on this slide. And then this slide gives us one more formula which looks at highs that may occur as a result of a surgical procedure. This can also be applied to the use of acute care devices such as ventilators or intravenous catheters using the same formula. Device-specific rates are calculated separately for each specific device. The following are steps used to calculate a device-associated infection rate, which include: Step 1, decide on the time period of analysis. Step 2, select the patient population for analysis, or the unit or area of the hospital that, again, we want to analyze. Step 3 is select the type of infections to be included in the numerator. Step 4 is to determine the number of device days that should be used in the denominator. And then step 5 is to calculate the final device-associated infection rate using the multiplier of 1,000 device days. The device utilization rate, or DUR, can be calculated for a comparison of device risk over a period of time. It expresses risk based on the amount of time the device is used and is comprised of these 5 steps. Step 1 is to decide on the time period for analysis. Step 2, select the patient population for analysis. Step 3, determine the number of device days to be used in the numerator. Step 4, determine the number of patient days for the denominator. Step 5, calculate the DUR using the following formula. And then the standardized infection rate, or otherwise called SIR. The SIR is a summary measure that compares the HAI occurrence among one or more patient groups to that of a standard population. The formula is the one shown here on this slide. Healthcare epidemiologists generally have the responsibility of establishing or consulting on the establishment of surveillance systems used throughout the healthcare institution. These surveillance systems are used to establish baseline rates, detect and monitor outbreaks, identify areas for risk management and quality improvement, provide evidence to support policy and procedure interventions, guide antibiotic administration practices, and provide interinstitutional data for benchmarking and comparison. The surveillance system also establishes process measures to monitor interventions and procedures, such as vaccination rates among healthcare workers, hand hygiene compliance rates, and compliance with surgical antibiotic prophylaxis. So the establishment of a surveillance system then must include clear goals and objectives of the surveillance system, standardized case definitions, valid and reliable tools or instruments to collect data, and then established and consistent epidemiologic formulas for the calculation of rates. Specific activities and areas of responsibility for the healthcare epidemiologists in incident management are preparedness, mitigation, response, recovery, and future prevention. Each of which, basically is exactly as it sounds. And then antibiogram. An antibiogram is constructed collaboratively between the healthcare epidemiologist and clinical laboratory professional. The antibiogram is generated from antibiotic sensitivity surveillance systems. The goal of this antibiogram sensitivity surveillance system and report is to estimate the proportion of selected bacteria that are resistant to antibiotics. This information also is then used by healthcare providers who are prescribing antibiotics to know what antibiotics the common organisms in the respective healthcare institution are most likely to be sensitive to for therapeutic purposes. Primary care epidemiology describes the application of clinical epidemiology into primary care practice. This clinical information can then be used to help inform population-level epidemiology as well. So primary care epidemiology applies epidemiologic principles and methods to healthcare problems encountered within a primary care setting that includes, but is not limited to, disease etiology, diagnosis, and all levels of prevention, including primary, secondary, and tertiary prevention. And lastly, evidence-based practice in healthcare. Evidence-based practice must include research evidence, clinical expertise and experience, non-research-based evidence, and patient expectations, values, and needs. Evidence-based practice processes involve asking the right question, searching for the best evidence, critically appraising the evidence, determining the levels of evidence available, integrating clinical expertise and experience along with the patient's expectations, values, and needs, and evaluating the outcomes of your evidence-based practice decisions and interventions. And so finally, here is the end of my presentation and my discussion questions for this week. This first one, I will also admit I did steal from the book because I thought it was a really good application type question that would involve having to use one of the rate formulas I talked about during this presentation. So it reads, Hospital DU has a robust surgical service line. The average number of surgeries conducted per month is 2,300. For the month of June, there were a total of 2,180 patients who had surgery. During the month of June, there were also a total of 20 surgical site infections. So in this equation here, or in this problem, we want to determine the surgical site infection rate for June. And then the second one I propose for this week's discussion board reads, if you have any wild infection prevention stories from your current or previous workplace, please feel free to share because, I feel like we all learn best from experience, and who doesn't like a good story or two? And it's much easier to, I feel like, talk about those kinds of things rather than having to look up different things and all of the things. So anyways, sorry, just said things a lot. But that was my presentation for this week. If you guys have any questions, please feel free to reach out or give me a call, email, whatever works best for you. And have a great week.